Welcome to the webinar, Balance and Self-Care, Helping Learners Avoid Burnout and Depression. I'm Barbara Lewis. I'm the managing editor of DocCom, which stands for Doctor Communication, an online communication skills learning system for residency programs, medical schools, and hospitals since we began offering CME last year. Joining me today is John Christensen. Welcome, John.
Thank you, Barbara. It's good to be here.
Well, before I tell you a little bit about John's background, we wanted to welcome our over 200 attendees, some from around the world, from Egypt to Singapore and all over the U.S. And some of you are current DocCom subscribers, and others of you are new to DocCom. At the end of John's presentation, DocCom is going to be offering a free 1-month trial subscription, which will be on our last slide to tell you the code of how you can access it. And if you have any questions, please write them in the chat box. We may not be able to answer all of them during the webinar, but John will certainly respond to them afterwards. The webinar is being recorded, so you can pass this along to others or access the PowerPoint yourself. And soon you'll get an email link in about a week or so with a link to the recording. So let me tell you a little bit about John's background. He is a clinical psychologist and consultant in behavioral medicine and graduate medical education and physician well-being. He was with Legacy Health in Portland for many years, where he directed the behavioral medicine training and internal medicine residency. He also facilitates retreats and training in physician well-being, communication skills, and managing medical errors. And he is the co-editor of Behavioral Medicine, a guide for clinical practice. We have a lot to cover, so let's get started. I attended a medical school conference a couple months ago where one of the speakers discussed the problem of burnout and the tragedies of suicides. And since one of DocCom's 42 modules covers balance and self-care, I contacted the author, John, and proposed this webinar to help faculty, program directors, and others help learners, and he agreed. So here are some of the astounding statistics: that over 1 million patients lose their physicians to suicide every year, the ramifications of which are oftentimes errors and miscommunication, lack of communication. It's estimated that about 10% of all medical students are clinically depressed. And there's another statistic that says that 48% of physicians have at least one symptom of burnout. So this is a major problem that we're facing. So John, tell us, what is burnout exactly?
Well, Barbara, it classically contains these three components: emotional exhaustion, where we begin to feel like our empathy tank has run dry and it's hard to summon up any compassion for the next person that we meet. Secondly, depersonalization in our relationships, where we begin to treat others as objects in terms of how useful they are to us in meeting our goals. And we can do that with our coworkers, with our patients, with family members, and even we can begin treating ourselves as task processing machines. And the third opponent is a perceived ineffectiveness in our work. Next slide. So among the causes of burnout are what we might call the imposter syndrome, and that's the sense that many people have, many professionals, that there is a discrepancy between the outward appearance of competence that they project and their own inner insecurity. And there's this feeling that I've fooled others up until this time into thinking that I know something, but at any moment I might be unmasked for the fraud that I am. And often this feeling can surface at times of transition in one's training, like completing medical school, beginning residency, becoming a senior resident, moving into a fellowship, or even beginning our first job. A second common cause among physicians is compulsivity, which is really a normal trait that's either already in people when they come into the profession, or it's trained into them, but it includes this triad of doubt, the question, maybe I missed something, guilt, the sense that no matter how hard or long I've worked, it doesn't seem to be enough, and an exaggerated sense of personal responsibility. And this can then lead to a psychology of postponement where we begin to bargain with ourselves and we begin to say, well, as soon as I get all this work done, then I can relax. As soon as I get into medical school, then I can breathe more freely. As soon as I get into the residency I wanted, then I can have a life. Or as soon as I move into that first job. And the as soon as keeps receding like the horizon, and we never quite get there, and we keep postponing the things that make life worth living. Not only psychological factors, but I think organizational and medical system factors are part of the cause as well. I think it's telling that almost half of physicians are reporting some symptom of burnout, and so that tells me there is something systemic going on in how work is structured. And in training programs, often we can think of that as the hidden curriculum, which has to do with what we observe happening around us, what behavior gets rewarded, who gets more praise. An example would be we see people keeping their emotions under wrap, and so we begin to conclude, well, we're not supposed to have feelings about that either. Next slide. So the ramifications are multiple. We certainly don't reach our full potential as healers when we are burned out. We're less present to our patients. And sometimes burnout can be a risk factor for impairment due to chemical dependency, depression, or disruptive behavior. And certainly it leads to an erosion of our spirit. On an organizational level, it can certainly begin to impact the organization's ability to perform well in meeting its clinical mission. Next slide. I'd like to spend a little bit of time on this because I think often we think of burnout in a dichotomous way, that there are these people over here who are burned out and then there's the healthy ones on this side, when in fact I think it is a continuum of health that we all slide up and down through the course of our careers depending on what's going on in our lives. And at one end is well-being and flourishing and vitality, and at the other end is burnout. And in some cases, unfortunately, burnout can be a precursor to impairment. And not only individuals, but organizations can experience this continuum as well. There are many organizations that do quite well over long periods of time in meeting their mission. And then others offer less intense but can begin to move towards organizational burnout as they overload their capacities. And individuals can have an influence on how well the organization is performing, and likewise the organization has a huge influence on whether the individual clinicians are at the well-being or burnout end of the continuum. Next slide. So I'd like to think about burnout and well-being in the context of an ecological model where this notion of carrying capacity refers to the maximum size of a species or a load that a particular environment can sustain indefinitely. So we know that the carrying capacity of various systems is finite, including the Earth, including specific ecosystems within which we live. And it also is true of our healthcare organizations and we as individual clinicians. We all have a finite carrying capacity. Next slide. Sometimes land use planners, when they're trying to estimate how much additional load or human population a region can accommodate, use this equation C minus L equals M, capacity minus load equals margin. Where the capacity is greater, than the increased load that's placed upon it, there is a positive margin, and that growth is sustainable over time. Conversely, when the additional load is chronically overloading the carrying capacity of the land, then we begin to see a gradual degradation of the landscape and resources, and the region can literally begin to choke on its own success. And I think that this model applies also to us as individual clinicians and to the organizations within which we work. And this negative margin is what I would consider equivalent to burnout. Next slide. So what are some of the signs of negative margin or burnout on a personal level? Certainly these sleep deprivation, fatigue, irritability, these are familiar to us. The inability to sustain or focus our attention. Dissociation refers to what happens when we withdraw our attention from our body awareness and our emotions, and we begin to focus more cognitively and visually on our to-do list and the challenges of our work. And decontextualization is a mental process of abstracting things from their full context in which they are embedded. Thus we objectify others as well as ourselves. And I think these are all indicators of burnout. Next slide. Likewise, organizations can show signs and symptoms of burnout, including decreased patient satisfaction, decreased clinician satisfaction, more turnover in staff, the difficulty in recruiting new people, drops in quality, the erosion of morale within a training program. And when the organization begins to simply measure and incentivize instrumental behavior, that is, behavior that's oriented towards keeping the organization going, then I think that's another indicator of burnout. Next slide. And of course, on a planetary level, we're familiar with many of these alarming trends, including water scarcity. Even today, the UN came out with a more definitive report on how rapidly the planet is beginning to show more signs of burnout. Next slide. So as we move forward, it seems to me this model can help us think about how we balance capacity and load at all levels of our existence, including our own individual lives as clinicians, including the organizations within which we live, and the planet itself. Next slide. So how do we build capacity? How do we increase that carrying capacity? These are some of the ways that can make a difference. Certainly increasing our self-awareness, working to develop our own emotional intelligence, which includes developing a language for our emotions, learning to control impulses, delay gratification, learning how to regulate our moods and recognize emotions in others and develop our capacity for empathy. All of that is involved in emotional intelligence. Attending to our physical wellness, adequate sleep, nutrition, exercise. Developing our capacity for intimacy is key to be able to access social supports, which we know are critical in expanding our capacity. Taking time to engage in creative pursuits, to play, to enjoy humor, finding and pursuing a sense of meaning and transcendence in our lives. Where do we experience awe? And on an organizational level, appreciative inquiry is a powerful tool by which we can explore when we have been at our best as clinicians, as a clinical team, as a faculty, and trying to distill from that analysis and from that remembered experience the elements of high performance and high functioning. Next one. And reducing load is another part of changing that equation. So certainly engaging more in tasks where we can share the load through partnership and teamwork, learning to manage our values within the time that's allotted, increasing our own assertiveness to set boundaries and even to say no at times, becoming clear about what we mean by influence versus control. We control very little, but our influence can be great depending on how we apply it. Learning when we have enough money. When do we have enough achievement? When is there enough esteem, and being satisfied with that? And certainly always pursuing ways to simplify our work lives and our private lives. Next slide. So what can training programs do? I'm going to highlight 5 areas that I think can make a difference, and then there are others as well that we might touch on later. So the first would be learning that programs measure the wellness of their trainees, that they integrate well-being topics into the curriculum, that they provide opportunities for support, collegial support among the trainees, that they incorporate well-being retreats and training in mindfulness, and we'll go over each of these in more detail. Next. In terms of measurement, I think it is important that training organizations measure the wellness of their trainees as a program quality indicator, and I would recommend use of the Maslach Burnout Inventory to measure the burnout end of the continuum and the areas of work-life survey for the engagement end, and these can be located on the Mind Garden website that I've listed there. And that it's important that the aggregate scores for classes and for the total program be presented perhaps annually as a provocative discussion on what we can all do to improve wellness, and that at the same time the individual scores be provided confidentially to respondents so that they can compare their scores with those of their peers. Next slide. Integrating well-being into the curriculum is another critical thing, and I consider training in balance and self-care as an essential part of professionalism. There's a wonderful evidence base both from positive psychology and the growing literature on resident well-being from which we can draw these curricular components, and 2 of the resources are the DocCom module on balance and self-care, and in our behavioral medicine book, the chapter on trainee well-being. And most of these topics are gone into in much more detail in those places. Next. So some of the topics might be include maintaining health, developing a personal philosophy, for example, of how whether we are able to influence things as opposed to controlling them, developing a philosophy of change that allows us to be open to the inevitable changes in life, whether it be changes in how work is structured, changes in healthcare, changes in our own aging, and how we make peace with uncertainty, developing a tolerance for ambiguity, which is essential for us to be present to the ongoing flux of experience. Learning to manage medical mistakes by understanding our own cognitive biases, learning to accept responsibility when inevitable mistakes occur, learning how to disclose errors to patients, and learning how to talk about our mistakes with colleagues so that we can all learn from them. Next slide. These are other topics that certainly can fit into a curricular organization on well-being, how to pursue spiritual growth, learning about the impact of spending time in nature on our own health, how to give and receive feedback. Next slide. Another important component that training programs can promote is collegial support, having a protected schedule time within which trainees can come together and explore in a confidential, private setting their challenges, their feelings, their successes and failures, what they find meaning in. And I think for this to work well, it's helpful to have a skilled facilitator who's not involved in a major evaluative role in the program. There can also be ad hoc support groups, for example, with an ICU team that has experienced a rash of patient deaths or difficult challenges. In addition to that, there can be self-led groups, and one example is the Finding Meaning discussion groups that were developed by Rachel Remen, and here's the website within which the protocol for running these sessions can be downloaded. Next slide. Well-being retreats are another wonderful addition to a training program's curriculum, and these can be full or half-day retreats in a relaxed setting. It's important to me that they be scheduled on a work day so that it communicates to trainees that this is an important part of their training. 2 or 3 times a year would be great, and these are opportunities for the participants to deepen their reflections and skills on promoting their own well-being as well as building their community. Next slide. And examples of these would be would be a team building retreat such as a ropes course or a hike in nature, or a wisdom of the body retreat which introduces participants to personal care practices such as Tai Chi, yoga, meditation, and massage. Next. I think mindfulness is a really important part of training. This is our dog Hercules looking out on Mount Hood from the shore of Lost Lake, and for me the essence of mindfulness is present moment awareness, where we suspend judgment on the experience, and it keeps us in the moment. Mindfulness can be taught and learned, and it's definitely working its way into the mainstream of medicine and also the military and police forces and many different endeavors. Through mindfulness, we learn how to increase our attention to patients, expand our capacity for empathy, our self-awareness of our own biases, including our cognitive biases, thus reducing the risk of clinical errors. And we learn to tolerate our own emotions and those of others, learning to regard them as weather systems that are passing through rather than something to which we must cling. Next slide. There's a wonderful study that was done on the impact of mindfulness training for a group of primary care physicians in Rochester who underwent an intensive educational program in mindfulness over an 8-week period. And the significant outcomes after 18 months included improvements in their own capacity for mindfulness, reductions in burnout as measured by the Maslach burnout inventory, a decreased mood disturbance, increase in empathy towards patients, and improvement in conscientiousness and emotional stability. So there was a huge return on investment for the clinic in providing the training and the time for these clinicians. And I think it underscores the fact that there is a growing literature and evidence base that shows us that for organizations, including healthcare organizations, to promote the well-being of their clinicians actually improves the performance of the organization and their financial sustainability. Next slide. And these are some of the other thoughts about what training programs can do. One would be requiring each resident to have their own primary care physician, and some clinics, both primary care and specialty clinics, are now requiring this as a contractual obligation of their clinicians. And not only is it important to have a PCP, but to have the time off to see the doctor. Also having a well-being committee that can monitor changes in the program and look at everything through the lens of how it is promoting the health and well-being of trainees and staff and faculty. Next slide.
John, we have a question here. Somebody has asked about the Maslach burnout, and he says that it's copyrighted and it does cost money to use, and he was wondering if there were any other validated burnout measures that you knew about that do not charge a fee?
I'm aware of a surrogate that has been used by the Mayo Clinic. Tate Shanafelt, who's done a lot of research in this area, has used a shortened version of this that they developed. But I still think the gold standard is the Maslach burnout inventory, and the cost is not prohibitive. I think ordering answer sheets in bulk is, we use that in our residency program, and several other healthcare organizations that I've worked with have used it. And so I would still recommend that as the gold standard. So I would like to conclude my portion with this image, which is the Great Wave off Kanagawa. And it's from a woodblock series that was done in the 1830s by the Japanese artist Hokusai Katsushika. And there are three elements in this image that, for me, summarize what we've been talking about. And I think the first and most obvious component are the waves, which are incessant and chaotic and can seem to threaten the boats and threaten everything in their path. The second component is Mount Fuji, which is that still point around which everything swirls, within which the chaos swirls. And for me, this represents ways we can center ourselves through mindfulness, gaining a larger perspective on life, cultivating intimate relationships, learning to become a contemplative in action so that we can meet the waves that come at us each day with a certain equanimity. And the third component are the people in the boats, which to me represent we and our colleagues working together as a team to keep the boats headed into the waves. It requires community, it requires collaboration, communication, and creativity. And with that, Barbara, I'm going to turn it back to you.
Thank you, John. That was just great. Such important information. We did get somebody that wrote in that talked about the Copenhagen burnout inventory, which is, quote, great, and there are no copyright issues. So before we sign off, I just wanted to briefly tell you about DocCom, and the last slide will give you information on how to get a free 30-day trial subscription. We were co-founded in 2003 by the American Academy on Communication and Healthcare and Drexel University College of Medicine. We currently have over 75 institutions. 6 journal articles have been written about the value of DocCom based on studies. We're in 9 countries and have been translated into 3 languages. So we have 42 modules that are online. Balance and self-care, of course, is one of them, and there's a lot more information available in that module when you get the trial subscription. We have over 400 videos that are realistic, unscripted, of clinician and patient, interactive videos, and then we have a lot for the faculty on grading and different aspects of teaching, including a curriculum guide. So you probably know the evidence-based information about the importance of communication skills, improves medical outcomes, decreases malpractice claims, enhances both physician and provider satisfaction. And these days, the HCAP surveys mandated by the government for hospitals and soon physician practices, you receive Medicare funds depending upon what your score is. It's been discovered that the drivers of the HCAP scores are indeed the 2 communication dimensions that are included. So here's a sample module. All of our modules are basically the same. We have a very consistent format, a rationale. We have patient views, the clinician views, content, videos are interspersed. You can go down through a video and it will highlight what two of them are talking about. And then if you click on the icon here, the clinician pops out and in this case talks about what his goal is, or the patient will talk about what she's thinking at this point in the conversation. We have this great empathy understanding video in our Module 6 where a learner can go through and click on where they think an empathic comment should be made between the clinician and the patient. And I've gone through this several times, and each time I get better and better at my empathic comments and where they should be inserted. So here are a few things for the faculty: easy to make assignments, dates, easy for grading. We have color-coded for grading. Here's where the students' names would be, all the modules across the top, dark green if you get a high score, going down to red if you get a very low score. And we have facilitation guides for the faculty as well as curriculum guides. So here's the information about DocCom. You can go on the website and click on subscriptions, and the code is WebMay16. It is case sensitive, and you will get a free 30-day subscription. So I wanted to thank you very much for attending. This webinar was recorded, and you'll be getting an email with a link in a week or so you can have the PowerPoint slides. I know that a couple of you had asked about that. We have a very short survey afterwards, and this is really a pilot program for DocCom. This is the first time that we have had a webinar regarding content, and I'd love to do more, but let me hear your feedback and what you thought about this topic, and if you have any ideas for future topics. Any questions that we didn't get to will be answered within a day or so. And thank you, John, once again.
Thank you, Barbara.
And thank you to all of you for attending.